Dear colleagues and viewers, we would like to welcome you all to the first joint educational initiative under the collaboration of European Society of Anesthesiology and Intensive Care and the Young European Resuscitation Council. In this webinar, we'll be talking about the latest national audit project, NAP7, on perioperative cardiac arrest. I am Dr. Miraç Selcan from Atatürk University. It is a great honor to host this meeting as a representative of the ESAIC Trainees Committee.
Hi, I'm Laura from the Young European Resuscitation Council, and it's my great pleasure to introduce our first speaker today. It's Jasmeet Swar, the clinical lead in the NAP7. He is a consultant in anesthesia and intensive care medicine at Southmead Hospital in Bristol, UK. The NAP7 report came out with a whopping 567 pages and has already given out 17 papers and counting. So a warm welcome to Jasmeet Swar.
Can everybody see my slides okay? Yes, excellent. So first of all, thank you to the Young ERC and the European Society of Anesthesiology and Intensive Care for inviting me to speak tonight. I'm going to talk about NAP7, which is the National Audit Project of the Royal College of Anaesthetists and the Centre for Research and Improvement at the college. And I'm going to start. This is a big project. There's 39 chapters and there's 17 publications, as you've already been told by Laura. And I'm just going to focus on the headlines. And then our second speaker, my colleague, Dr. Andrew Kane, is going to then give you some more information that comes from the project. So in terms of the project, the title of the report is At the Heart of the Matter. And the focus of the project is perioperative cardiac arrest, as you've heard. And if you want to tweet about the talk, there's a hashtag, and it's hashtag NAP7. Now, if you want to read the report in full, you can go to the college website. If you just Google NAP7, and you can do the report, and there's 39 chapters, or you can link to particular papers. So there's, for example, a methods paper, an activity paper, and so on. So everything I'm going to say is freely available, including most of the slides. So for those of you who are in a hurry, you can just go to the national daily paper, The Sun, which is a tabloid, and the Sun headline for the report that came out on the day of the report was heart-stopping. Almost 1,000 Brits go into cardiac arrest on the operating table every year, NHS study suggests. So there's a headline for you. If you want to know more, a little bit about the National Audit Project. So these have been going on for a while, and there wasn't really a NAP1 or a NAP2. It's just that the third project that the college did, which was the National Audit Project, got called NAP3. So NAP1 and 2 don't actually exist. And NAP3 was about major complications of central neuroaxial block in the UK. And that gave us things like the risk of permanent neurological damage after spinal anaesthetic is 1 in 50,000. Right, so that was NAP3, and that covered regional blocks. NAP4 covered major complications of airway management. From that, there's been quite a lot of learning in terms of difficult airway drills and so on. NAP5 covered accidental awareness during general anaesthesia, and has sort of led to increases in use of processed EEG and how to manage people who have awareness. NAP6 covered allergic reactions or anaphylaxis, and again, lots of learning. So, so what are the common causes of perioperative anaphylaxis? So NAPs tend to cover topics that are rare, poorly studied, potentially catastrophic, important to patients, important to anaesthetists. And there are also areas which are quite hard to study because no individual anaesthetist or department may see many cases. So it relies on everybody in the country pooling their cases together. And I think everybody would agree that a common fare of patients is, will I wake up after my anaesthetic? And if you look at big surveys, and here's an example, there's a survey published a few years ago where they asked 1,000 people, and their fear of death during the operation was their biggest concern, especially if having major surgery and if they tended to be younger. So I think in terms of, our patients, it's a bit like a lot of people are worried that if they have an anaesthetic, will they wake up afterwards? So it's important to patients. So perioperative cardiac arrest was the topic, and we defined perioperative cardiac arrest as a period that started at the point where the anesthesiologist started the first hands-on contact with the patient. So either in the starting anaesthesia, so that could have been the sign-in with the patient before you put them to sleep, or cannulation. And we included the period in the operating room, or it could have been in the interventional radiology suite or the delivery room, or other areas where anaesthesia takes place. And we included it up to the point where the patient went home, or up to 24 hours after they were handed over in the recovery area. So we had this core period in the presence of anaesthetist plus 24 hours afterwards. And if the patient went home after 12, once the patient went home, they weren't included. So most of our good data comes from the time with the anesthesiologist. And we had lots of stakeholders on the project. So in the UK, we had the intensive care medicine faculty, the Vascular Society, the College of Surgeons, Cardiac Anaesthesia, Paediatric Critical Care Society. We had the Young Trainees or Junior Doctors Anaesthesia Research Group, anaesthesia assistants, and all the various stakeholders. And we had quite a big faculty. In terms of collaboration, every department and every anaesthesiologist in the UK took part. So it was a big project, and we had a core group. Myself and Professor Tim Cook were the leads, and we had 4 fellows: Andrew Kane, Richard Armstrong, Amira Kasimovich, and Fiona Oglesby. And Andrew, you'll hear from in a moment. So the project consisted of 3 parts, and there was a baseline survey of every anaesthesiologist in the UK and every department, and that was to find out about what were the structures and processes in place to care for patients having perioperative cardiac arrest in emergency, so availability of defibrillators, difficult airway kit, drugs, algorithms, and also asking anesthesiologists if they, what their experiences were of cardiac arrest and treating cardiac arrest and the impact on them. So that was the baseline survey. Then there was an activity survey, and Andrew will talk about that in a bit more detail later, where we got every department in the UK to do a census of every case over a 4-day period. So my department may have done Monday, Tuesday, Wednesday, Thursday, and departments were randomly allocated to 4 days. So it could have been Friday, Saturday, Sunday, Monday, or Saturday, Sunday, Monday, Tuesday. And every anesthesiologist had an app where they could enter their cases, and they could also enter complications and events that occurred during their cases. And that allowed us to get some measure of denominator data, so how many cases, how many vascular cases there are, or how many times people become hypoxic or hypotensive. And then the third period was a reporting period, and this was from June 2021 to June 2022, where we got every department to report every single case of perioperative cardiac arrest. And that was 881 cases. And all the case reporting was anonymized. So the process for collecting all this data was a one-way flow of data. And as a research group, we didn't know who reported the cases or which hospital they came from. So it meant that people could write quite a lot of information, and if they'd had an argument with the surgeon or whatever, and we wouldn't be able to, it was all anonymized and confidential, so we wouldn't be able to trace it back to who'd reported which case or which hospital. So there were three parts. The baseline survey took place at the beginning of the project, so about June, July, August 2021. The activity survey took place in sort of the middle, so November 2021, January, February 2021, and then the case reviews took place over a whole year. And the first big number I'm going to give you is, we estimate that the anaesthetic workload over that year was about 2.71 million cases, and based on the activity survey and other data. So that's our sort of denominator number of cases. And the next thing was we had 881 perioperative cardiac arrest cases. So that gives, and I'm giving it to the nearest thousand there, it's about 1 in 3,000 cases had a perioperative cardiac arrest. And I forgot to mention, by perioperative cardiac arrest, what we actually mean is the patient has to have chest compressions and or defibrillation. Now, what about incidents? And most of these cases occurred in high-risk patients. So if you were an ASA1 patient, your risk of cardiac arrest was very rare, and it was about 1 in 11,000. And your risk of death was about 1 in 132,000. If you're ASA1 or 2, again, very low risk. So if you look at this, most of these perioperative cardiac arrests are actually occurring in relatively high-risk groups. And if you go to the main report, you can dig down deeper into the data. I'm just going to give you some of the headlines. And the highest risk groups are actually at the extremes of age. So very, and this is fair, neonatal surgery, elderly, frail patients. The other high-risk groups, males, people having emergency surgery, people with comorbidity already in hospital, people with heart disease, and patients having surgery maybe at the weekends or late at night. But this is just a univariate analysis, because in most hospitals, most of the elective low-risk surgery is done Monday to Friday during the day, and the only high-risk cases, the only cases done during the night tend to be very high risk. So you do see more complications, more cardiac arrests out of hours. And so I think the highest risk areas tend to be very, older, frailer patients, neonates, and people having emergency or urgent surgery, especially out of hours. Now, what about which specialties had the highest prevalence? So where did most of these cases occur? So most of these cases occur orthopedic trauma, lower GI surgery, cardiac, vascular, interventional cardiology. So that's where most of these perioperative cardiac arrests are occurring. And this graph is trying to sort of, so along the x-axis is the denominator, and along the y-axis is the number of cardiac arrests, and the size of the circle is how big the problem is. So cardiology, cardiac surgery, vascular surgery tend to get proportionately much higher incidence of cardiac arrest, and whereas obstetrics, it's actually relatively low risk. Whereas general surgery, orthopedic trauma have high numbers, but compared to the total number of cases done, it's relatively smaller. And you can look at other specialties on there. And clearly there's some hot spots. If you've got cardiac specialties, neurosurgery, radiology, even though the numbers may be smaller, they're sort of relatively high representation. And at what phase of the anaesthetic do cardiac arrests occur? So some people arrested before the anaesthetist gave them any drugs, and that usually means they're already very critically ill, and they probably had a fatal underlying issue such as ruptured aneurysm or major trauma. Then there's a group of patients who arrest at induction, and then there's a group who arrest in the transfer, and depending on the system you work in. So in most UK hospitals, patients tend to get put to sleep in an anaesthetic room, and then they get moved from the anaesthetic room into the operating room. And that may be a blind spot in monitoring or whatever while they're being moved. So there is a group of patients who are getting cardiac arrest in there. Then there's a fair few who arrest before the surgery starts. The majority of arrests, or a large proportion, occur during the procedure, and then there's more other peaks if you've had a regional block or local where the anaesthetist decides to convert to an anaesthetic because general anaesthetic, and then there's peaks at extubation, in recovery, and then post-operative. And I think the area which is of interest is those that occur before the surgery starts, because they're the ones that the anaesthetist has most chance of modifying. And then the peak that occurs during surgery is just because most of the time the patient's at risk occurs during surgery. But I'll go into that in a bit more detail. So the causes of cardiac arrest, the commonest in the perioperative period is major hemorrhage. And that could be due to the underlying disease process, so a ruptured aneurysm, but it could be caused by the surgeon, injuring a vessel or, losing control of hemorrhage. And then the second commonest cause was bradyarrhythmias. And these are, everybody who's given anaesthetics probably had bradycardias, but these are patients who've had sustained bradycardia leading to asystole. And we excluded patients who only had 1 or 2 chest compressions. So the only patients who were included in that definition were people who needed, a fair bit of CPR, as opposed to just a brief bradycardia. And then the final commonest cause was cardiac ischemia. And these causes varied according to specialty. So for abdominal surgery, septic shock contributed in most cases. Cardiac surgery, cardiology, it was cardiac ischemia, ENT, hypoxemia, gynecology, bradyarrhythmias, and so on, and vascular major hemorrhage. So I don't think there's any big surprises there. And all we've done is quantified what people think, in terms of actually this is sort of matches what most people would see in their practice. Now, so every case was reviewed by an expert panel, and we looked at why did the patient arrest, and in nearly all cases there was a patient reason. The patient had severe comorbidity, or they had a process that was going to lead to cardiac arrest, irrespective of the anaesthesia. In about 40% of cases, we thought the anaesthesia contributed to the cardiac arrest. So maybe the choice of drugs, the choice of airway technique, or the anaesthetic technique, or the dose of drugs. And in about 35% of cases, we thought it was surgical factors. So a surgical process leading to major hemorrhage. So there were patients who can have multiple different causes. So these were overlapping. What about the cardiac arrest process? So the majority of arrests had an initial non-shockable rhythm, and that was either PEA or PEA progressing to asystole, and 79% of cases got adrenaline, 17% were defibrillated. So these are just the headline figures, and if you go into the report, there's a lot more about dosing of adrenaline. Now, 76% of patients got ROSC, and 59% were alive at the time of reporting. And of those, the majority went home. And if you look at survival by age, so the blue bars are proportional survival. So survival was best in younger age groups and then got worse as people got older. If you look at survival by duration of CPR, most of survivors had less than 10 minutes of CPR. And then you see it decreasing. But there was clearly some people who did quite well after quite a long period of CPR. So, there will be some people who benefit from prolonged CPR. And then patients having elective surgery who had a cardiac arrest did much better than those having urgent or more immediate surgery. But a large proportion of the people in that immediate group would have been people with quite severe injuries. We also rated the quality of care, and overall it was good in most cases. There's good and poor aspects in 28%, poor in 2.1%, and where care was poor, it was often leading up to the cardiac arrest. Once cardiac arrest happened, care tended to be quite good. What about surveying? So we surveyed all the departments of interest. Depending on where you work, there's a lot of different ways of calling for help. Most places have an emergency bell that you ring, but some hospitals have bells that you ring. Some places have whistles that you blow if you need help. There's quite a lot of variation in hospitals, and I'm sure there'll be other variations around Europe. And then when we spoke to anaesthetists, about half had attended a cardiac arrest in the previous 2 years, 85% during their career. Most were confident in managing arrest, but less so speaking with patients and families. And if you had been at a cardiac arrest, it did have an impact on your ability to deliver future care. And, if you look at all cases, 4.5%, if the patient died, 5% of people then had problems in their work later on. If it was an obstetric case or a pediatric case, even more. So if you look at that, people said yes, not sure, didn't want to say, or no. And clearly, the worse the outcome, or if it's a child or a pregnant patient, it tends to have a bigger impact. And that could mean in some patients, for some anesthesiologists, not carrying on with anesthesia. I'm going to stop there just to remind you that I think the NAP7 project has shown in the UK, and I'm sure elsewhere in Europe, that anesthesia is reassuringly safe for the vast majority of patients. So they will wake up during their anaesthetic. They will wake up after their operation, not during their anaesthetic. And most of the risks are occurring in high-risk settings. And one of the things that we did in this project was have patients involved, and we had surgeons. And one of the important things was that everybody needs to remember when a patient comes for an operation is that it's a patient that takes a risk, and our role is to make that risk as small as possible. Now, I've given you the headlines. I'm hoping Andrew will give you some more detail on some aspects of the project. Thank you.
Thank you, Dr. Swarf, for this presentation. I'd like to introduce our next speaker. Andrew was a clinical fellow in the NAP7, and he's a consultant in Department of Anesthesiology at James Cook University Hospital in Middlesbrough, UK.
Thank you very much, Marek. I'm just trying to make my screen work. Is this presenting on the bottom of here?
We can see you okay.
There we go. Lovely. You can hear me and see me. Lovely. So thank you very much, Marek and Laura, for the invitation, and from the Young ERC and other collaborators for hosting this evening. Well, Jazz has really stolen my kind of first slide, really, which is all about risk. and to say that it is the patient who takes the risk. This was a quote that was repeatedly told to us throughout the project by actually not an anaesthetist, actually our surgical representative, Simon Kendall, who's a cardiothoracic surgeon. And he said that we might think that, you know, we as anaesthetists or perioperative physicians, intensivists, or even our surgical colleagues are in control of what's happening. But actually, at the end of the day, it's the patient who takes the risk for everything that we do to them and for them. So Jazz has told us a lot about what happens to patients who have cardiac arrests, what the chance of them having the cardiac arrest is, and the chance of recovering from a cardiac arrest. But what does NAP7 tell us about risk for patients in general having an anaesthetic? Well, it's the activity survey which tells us a lot about this. So the case registry, which Jazz talked about, tells us about, if you like, the 1 in X, the so-called numerator data. And the activity survey tells us about what we call the denominator data. This is the X in 1 in X. And we performed a fully electronic survey of all cases done by all anaesthetists on all sites across the whole of the UK for 4 days at the back end of November 2021. And we collected patient-level data for all of those patients, including age, ASA, BMI, frailty score, and other surgical factors. And we also collected data which we thought was pertinent to the specific NAP theme of cardiac arrest. So we collected lots of events which the panel, the stakeholders, felt may be either serious enough in themselves to lead directly to cardiac arrest or maybe contributory to cardiac arrest. And the period at which we surveyed was this period here between the start of the WHO checklist, and the period really where we hand over to patients in the recovery room in the UK. So what did we find? Well, we had 416 individual sites across the whole of the UK who were invited to take part in England, Scotland, Wales, and Northern Ireland. And of those, 85% participated, so huge participation across the whole of the UK. And there were overall 24,172 individual cases included in this part of the project. And for those who get excited about data, that's over 300 cases an hour that were going into the database. And as Jazz mentioned earlier, we estimated that that equated to, at that point in time, an annual case rate of around 2.72 million cases per year, accepting that in the back end of 2021 in the UK, we were in a kind of grumbling Delta wave of COVID. And it was a period just before we saw a huge Omicron surge in sort of Christmas, New Year, 2021 going into 22. So what does the population of patients look like that we look after in the UK? This is a population pyramid. So you've got down here from, you know, neonates, infants, all the way up to 85 years and over. And the first thing to say is it's not unexpected. There's peaks in childhood of patients that we look after, and there's also peaks in middle age, older age. And if you kind of sort of deliver this obstetric bump, if you like, it's more or less 50-50 in terms of males and females. What's noticeable is at the extremes of age, both infants and neonates, and at the other end, those who are very elderly, over 85, there's less of those patients. But interestingly, that really is where most of the risk is. If we look here at the anaesthetist reported or anesthesiologist reported ASA by age, you can see the white bars are ASA 1, these are ASA 2, and ASA 3 is the red. So if you're a neonate, even though most neonates are fit and healthy and go home on day 1 or 2, if you're a neonate and you're coming to theatre, well, it's because there's something sadly quite wrong. And so most of those are ASA 3. At the other end of life, if you're over 75 years of age or so, you're also more likely to be ASA 3. That's the median ASA in those groups. But it's not all about ASA and age. I think frailty is also possibly more impactful, and we've certainly seen when we've looked at what we call the older frail population, so patients over 65 years of age with a Rockwood clinical frailty score of 5 or more, that there is more chance of having a cardiac arrest and also a higher chance of doing more poorly. And in the UK, if we look at patients who are CSF 5 or more, 65 years old, the sort of reddy brown color. In the sort of age range of 66 to 75, it's about 20%. Then it increases to about 35, almost 40% over 75. But in the group over 85, almost 2/3 of the patients that we look after are clinically frail. And as they increase in their clinical frailty score, they accumulate comorbidities or multimorbidity. And they also have a much higher chance of presenting not for elective surgery, but for emergency surgery. It's almost sort of a mirror image of what happens in the neonatal group. So here you can see proportion of patients admitted for day case surgery decreases almost to about 0 in the higher frailty score groups, whilst the green and the sort of purpley colours here representing emergency surgery become the mainstay for those patients. What does the project tell us about how things are happening over time? So Jazz told us that these projects have gone back sort of 15 years or so now. So NAP3, which was on neuraxial block, was back in 2009. NAP5 was the first project where the activity survey was standardized in terms of the questions that were asked. And so through NAP5, 6 and 7, which have happened over the last 10 years, we're able to see something about trends in anaesthesia in the UK. So first of all, what about age? Well, the median age of the population that we look after in the UK has gone from 50.5 years to 52.8 years, an increase of 2.3 years. And you might say it's not unexpected. The populations across the whole of Europe are increasing in terms of age. Well, in the UK, the Office for National Statistics suggests that the median age has only gone up by about 0.4 of a year during that time. So the perioperative population, if you like, is aging at a rate which is higher than the general population of the UK. And if you look here in every age group over 66, you can see the proportion of patients in each group, and in NAP7, which is the red bars, they've gone up by 1% or so in each of these. And that might not seem by much, but when you're looking at 2.7 million patients, that's actually quite a significant shift in terms of the age of the patients that we see in perioperative care. What about the rates of obesity within the patients that we look after? So this is for the adult non-obstetric population, a histogram of proportion of patients in each BMI class. This is normal. This is what it looked like 10 years ago. In NAP6, which was in 2016, there was a hint that the amount of normal BMI patients was reducing in the UK. But what we've actually seen is a really huge drop in the amount of patients who are of normal body mass index in the UK. And we've seen a corresponding almost 9% increase in the proportion of patients who are clinically obese, such that now the median BMI, which was normal 10 years ago, is now well in the overweight category. And there may be multiple reasons for this. That might be a background trend anyway, but this is probably coming off the back of COVID lockdowns, less exercise, patients waiting for longer periods on operating lists. Sadly, it wasn't confined to the non-obstetric population. The obstetric population was arguably even worse in terms of the patient. This is not all obstetric patients. These are patients who we encounter as anaesthetists wanting labour analgesia or coming to theatre for caesarean sections, for example. And you can see the amount of patients who have normal BMI has gone down quite a lot, over 12% increase in patients who are obese in that group. What about comorbidities? Well, on a basic level, comorbidity is measured in the UK and around the world, really, using the ASA score. And 10 years ago, fit and healthy patient represented about 38% of the work that we do, and that's gone down to 24%. And we've seen corresponding increases in ASA2 patients up 5%, ASA3 patients up 6%, with ASA4 and 5 being roughly the same. So an increase in age, increase in rates of obesity, increases in the amount of comorbidity and multimorbidity in the population that we look after. And I think it's true to say that we probably underscore ASA. So the ASA scoring system has quite, since 2014, quite sort of strict examples of what is an ASA 2, 3, 4. And, you know, if you've had a CVA, a TIA, or a stroke, you are by definition ASA 3. You can't be ASA 2. But in our activity survey, people were scoring these patients as ASA2, so there's underscoring. And I think the things which were highest in terms of underscoring were recent myocardial infarction was less recognized, and severe valvular dysfunction, which automatically makes you an ASA4, was often unrecognized as a cause of increasing your ASA score. So when you put all of this together, combined with the fact that the waiting list in the UK is up to about 8 million people, not all waiting for operations, but waiting for procedures of some description, almost 1 in 10 of the population in the country, you can kind of understand why in the UK, and I think this is possibly similar in other countries across Europe, we are really struggling with our kind of perioperative workload and trying to do the best that we can for our patients. So that's what the patients look like who might be waiting on our lists for surgery. What might face them when they come? So during the activity survey, we asked people to report complications which occur during anaesthesia. Now on the left here, this is a information sheet which the Royal College of Anaesthetists in the UK supply to helpfully tell patients who are coming for elective surgery what complications may occur and what frequency they may occur in. And they give them those in sort of everyday language, very common being more than 1 in 10, common 1 in 100, uncommon 1 in 1,000, so on and so forth. And what we thought we would be interesting and important to do as part of this project was to look at complications beyond those that we commonly tell patients about. And so the stakeholder panel, before we started the project, came up with a list of complications that we thought were, as I said earlier, potentially serious enough either to leave the cardiac arrest in their own right or may in combination lead to complications that could lead to cardiac arrest. So these aren't things like missing a cannula or bashing a lip. They're things like airway hemorrhage, cardiac ischemia, significant acidosis, LA toxicity, potentially serious things. And how many of these potentially serious complications did we see? I think for us, it was quite staggering that 1 in 18 cases in the non-obstetric population had 1 or more of these potentially serious complications occurring. And they occurred across the sort of A, B, C, D, E spectrum. Most of them were circulatory in nature, about 1/3, followed by airway, which represented about 1/4, then breathing and metabolic came in together with about 15% each. And they didn't all happen in isolation. There were several cases, several hundred cases, where we had combinations of complications occurring together. Now, the next slide looks quite complex, but I'm going to try and break this down to its bare bones. So on the left here, what we have are the different complications that are in that list. So airways, so we've got laryngospasm, failed mask ventilation, so on and so forth, breathing, circulation, and the relative chance of having these complications as color-coded on that risk scale, which I said earlier. So reassuringly, some things are extremely rare, supplying the wrong gas or an incompatible blood transfusion not occurring at all in the activity survey, which is reassuring. But there is one here that's red, occurring commonly, and that is severe hypotension, where central vasopressors were either considered or started. I mean, at a rate of more than 1 in 100 undifferentiated cases across the whole population in the UK. What if we look at the elective population? Well, reassuringly, that red box there disappears, and everything here is now uncommon. So that's 1 in 1,000 or less, which for the elective population, you can reassure your patients that any individual complication is uncommon or unlikely to occur. But in the emergency population, we found that lots of these boxes lit up with more reds, and they were severe hypotension, arrhythmia, major hemorrhage, septic shock, acidosis, and electrolyte disturbance, all happening at a rate of more than 1 in 100. And indeed, severe hypotension here is about 400 per 10,000 events, so about 4% of emergency cases. So that's cases either coming immediately to theatre or urgently on the emergency list are requiring central vasopressors for severe hypotension. But as with the whole of this project, you can't sort of box one patient in one box. The risk changes depending on the situation. So here it shows the relative chance of having at least one of those complications or more, depending on different age groups, for example, here. So actually, it's not the older patients that are at very high risk, it's the neonates, as I said earlier, ASA 3, 4, and 5, male patients, clinically frail patients, patients coming for urgent and immediate surgery, long operations, complex operations, although some minor operations can lead to cardiac arrest. And I think of note in the overall case registry, patients coming for OGDs, endoscopies as an emergency, particularly were at very high risk, even though it was considered minor surgery. And then those coming at the weekend and at night, and that's probably because it's interacting with them coming for emergency surgery or they're physiologically sick when they come to theatre. So I guess the question is, what should we or should we tell patients? Is this sufficient, which the college provides? And that's been the subject of a couple of editorials this year in anaesthesia, one from Tim Cook and another from Tim Meek on the back of the NAP7 data. And if we put the elective data into that kind of chart, we're telling patients that it's uncommon for them to have a minor nerve injury, but in the same bracket, laryngospasms there, or rare, damage to the teeth, 1 in 4,500, but also drug error and equipment failures were in the same bracket. So, what should we tell patients going forward, I think is an interesting discussion to have. And the Association of Anaesthetists have currently got a working party on this, and I think it'd be quite interesting and important to see what they've got to say going forward. So how does this link to the case registry? So in the cases, those 881 cases, which Jazz talked about, we felt that risk was important in at least 12% of those. We thought there were issues relating to risk assessment or scoring, often lack of it or a lack of communication to the patient or to the wider team. And this was particularly a case in patients who are older and or frail. And indeed, in those 881 cases, we didn't think it was impactful in all the cases, but 71% of the adult cases have no specific risk score used for them. And we felt that overall surgery-specific risk scores, whether they be SORT, NSQIP, NELA in the UK, were generally underused. And therefore, one of our strongest recommendations was that risk scoring should be a routine part of the perioperative assessment and shared decision-making process, and we should be including those in high-risk patients as part of the pre-list briefings. And you might say, well, that's nothing new, and I think we would agree. Indeed, these are the RCOA, Royal College of Anaesthetists, guidelines for the provision of anaesthesia services, and that says for a long time that as a minimum, all ASA 3 to 5 patients and those undergoing high-risk surgery should have estimated and documented risk scores going before surgery, but it's clearly not happening in all cases. And I think that's something that we could improve on going forward. So just to sort of wrap up really on my kind of highlights on risk in terms of the patients, we know that the ASA scores at the extremes of life are higher, and we underscore ASA in general, and there's a large amount of frailty in our population. We've seen significant trends in terms of age, obesity, and comorbidities over the last 10 years in the UK. Surprisingly, 1 in 18 cases has a potentially serious complication or critical incident. A lot of these must be managed extremely well and competently because actually the overall cardiac arrest rate is incredibly low. And in terms of risk assessment, it's lacking in a lot of cases that go on to have cardiac arrest. That's all well in hindsight, but going forward, we need to make sure that we are documenting, discussing, and acting upon risk scores. So I'd just like to say thanks to everyone who's involved in the project, particularly Jazz and Tim, who have mentored us as fellows. And I know this is a young ERC group, and if anyone's out there and wants to send me a message via Twitter or via email, I'm very happy to answer about how I got involved in the project. And if anyone has any other questions, happy to ask those.
Thank you, Andrew, for the presentation. I'd like to direct a question. As far as I've seen from the report, one of the most striking facts is that the major cause of cardiac arrest is seen to be hypovolemia, circulatory problems, and hemorrhage. And in spite of all the current guidelines being improved on fluid resuscitation and management of major hemorrhage, we see that this is still a major problem for management of anesthesia. Well, we can say that this might be a patient factor or a surgeon factor, but to reflect on what we can do to improve. In spite of all the new technology and devices on hemodynamic monitoring, still we have a lot to do on management of hemorrhage to decrease mortality and morbidity, obviously. So what are your views on this fact, and what do you think we can do for the next projects to focus on the management of hemorrhage, or maybe new guidelines, maybe?
Yeah, so that's a very good question. So the issue with major hemorrhage, it could be hemorrhage from another, so a major trauma patient, or hemorrhage that occurs as a part of complication occurring during surgery. And so the challenge for anesthesiologists is, the first challenge is, what's the optimal anesthetic technique in a hemodynamically unstable bleeding patient? Yeah, and clearly for hemorrhage, you want early hemorrhage control, and any anesthetic technique is going to be associated with hypotension, increase in thoracic pressure, and what the best way to resuscitate them is, and giving blood. But the ultimate intervention is stopping the bleeding, and our data showed that sometimes people were slow to get the patient onto the operating table, getting them off to sleep for hemorrhage control, or they arrested in the window between anesthesia and surgical control. Or inevitably, there's going to be some cases where surgical control of hemorrhage is not feasible because of severe injuries and so on. And so clearly it's an area where in our recommendations, we think if you're going to do training in your hospital, there's 4 emergencies that every anaesthetist should have done a practice simulation on every year: major hemorrhage, airway problem, acute airway problem, anaphylaxis, and can't remember what the 4th one was, but so cardiac arrest. So 4, so and they need to be well rehearsed by all anaesthetists, because they're the most likely issues that are going to cause severe harm to patients. And so in my hospital, we have a major hemorrhage protocol where if you ring a number, a team comes with cell salvage, the blood arrives, the porters bring the blood. And so it's every hospital needs a major hemorrhage protocol that's been practiced and rehearsed and tested. And then you need to be able to get access to surgeons who are good at stopping bleeding, or interventional radiologists, and so
on. Yes, thank you both of you for your excellent talks. And we are opening, as everybody can see, the questioning round. There is a question in the chat already. And it says, up to which point is an ECG flatline just a vagal reflex, and when is it asystolia? What would you say?
I'll answer that as well. You can carry on, Andrew.
Okay. Well, I mean, we in the project we had to be quite pragmatic in terms of what we decided a cardiac arrest would be. So we decided that a cardiac arrest, you would either have to have the patient be defibrillated and or have 5 or more chest compressions. So if you have a period of, say, you have insufflation of an abdomen during a laparoscopic case and you have a profound bradycardia for a screen and you don't do anything, then in terms of NAP7, we didn't count that as a cardiac arrest. When we decided on the kind of inclusion criteria, we knew that we would miss some things and some things might get included that otherwise wouldn't. So, for example, patients who had active do not attempt cardiopulmonary circulation orders when they came to the theatre and they were kind of carried on, then there might be patients who are having cardiac arrests who we wouldn't have captured. Equally, there might be patients, depending on clinical decisions, who get included. So if you've got, say, severe anaphylaxis with a period of hypotension, the point at which you start doing CPR, Laura, to the point at which I might start doing CPR might be different, and therefore we might have had different patients included. So I think, a cardiac arrest is a cardiac arrest if you decide it's a cardiac arrest, and then you start doing either CPR or defibrillate, and that's what we decided as part of the inclusion criteria. Jazz might want to elaborate a bit more.
Yeah, I think what counts is, so it's very easy for an out-of-hospital cardiac arrest, and you turn up and the person looks dead and they don't have a pulse. If you're in a perioperative, closely monitored setting, you ideally want to start your resuscitation when your patient's nearly dead or before they're dead, and not allow them to become dead, so to speak. So you've got to, and if you're monitoring them with an arterial line, you have beat-to-beat blood pressure monitoring, you may give adrenaline and fluid much earlier and then start chest compressions much earlier than if you're doing a blood pressure every 2 minutes with a BP cuff and you're then relying on feeling for a pulse. And so the point at where someone starts chest compressions is actually not an easy yes-no type thing. And the important thing, especially for young anaesthetists, is you've got to be prepared to tell your surgeon things aren't going well and the patient needs resuscitation. And one of the issues that I think is important is that we're not very good at knowing how useful chest compressions are in the setting of major hemorrhage. So if you have major hemorrhage, the primary intervention may be stopping the bleeding and restoring circulatory volume prior to then doing chest compressions. And so it depends on the cause of arrest. Whereas for something like anaphylaxis, you need early adrenaline plus or minus chest compressions. For airway problems, you clearly need to get oxygen into the lungs. And so even though the core activity of resuscitation is chest compressions and or defibrillation, in the specific scenarios that we see in cardiac arrest, you've got to tailor it to the particular patient's circumstances and the cause of cardiac arrest, which you should be able to, to clearly, if you have an airway problem, you've got to move through your difficult airway algorithm and get oxygenation established, even if it means doing front of neck access, a cricothyroidotomy. For anaphylaxis, stop the trigger, give adrenaline. And the chest compressions are just part of helping maintain a circulation while you're treating the underlying cause. And the only one other comment I was going to say is a dose of adrenaline, because people are starting chest compressions and CPR very early. A 1 milligram dose of adrenaline may be too much for lots of patients. And in the cardiac arrest setting in theatre, when you've got close monitoring or you've got an arterial line, you should be able to mainly use arterial blood pressure monitoring, end-tidal CO2 monitoring to maybe titrate the dose. So giving in an adult maybe 50 microgram boluses, 100 microgram boluses. It's only once you're in a full milligram would you think, actually, I just need to give 1 milligram every 4 minutes or start an infusion.
We have another question. How did you define hypertension? Did you decide it is defined as the fall of mean arterial pressure below 60 millimeter mercury, or is it like defined based on the baseline of each specific patient?
Andrew.
So in the activity survey, because the survey was going to be completed thousands of times, we had to have fairly pragmatic descriptions. And so, in fact, hypotension was the only one that we expanded in brackets and put central vasopressors considered stroke started. And the same with the definition of major hemorrhage. We left that open to the interpretation of the anaesthetist. And, you know, in the same way, you know, one person's hypotension might be different to another. And, you know, what you might consider a major hemorrhage, I might not, or vice versa. So there had to be some kind of pragmatic decision to do that. I think what we do see is that the data is kind of consistent internally, and when it comes to the cases and people reporting when they've estimated what the actual blood loss was, say during a major hemorrhage, or with patients who are severely hypotensive, then the physiology and the description kind of match up. So we think that we're getting kind of real world pragmatic data back about what's actually happening on the ground. May not be the experimental definition of what hypotension is, but it's practically what people observe and feel it to be.
Yeah, I think that's important because we're including children, neonates, elderly patients. So we didn't give a single value. We just said if you gave them central noradrenaline or adrenaline, or were considering starting it, that was good enough for us. That meant the anaesthetist was probably worried the blood pressure was low. It wasn't just easy to manage fluid and a little bit of peripheral vasopressor. It was if you're going to give it centrally or you started thinking about doing that.
I also have noted down some questions since our participants are a bit shy. One was that I noticed that the rates of emergency front of the neck access were lower. And I was wondering if you attribute it to the availability of video laryngoscopy, or did you have a different airway algorithm after NAP4?
Yeah, I think there has been one, but we didn't collect whether there was video laryngoscopy or not. There are events, but it was relatively low, and I think in the UK, quite a lot of effort has been put into getting people to follow an algorithm for difficult airway management and rescue devices. And I think our survey showed most hospitals had access to emergency airway equipment to be able to do airway rescue, apart from in remote areas such as scanners where anaesthesia, or in paediatric settings. So I think those just reflect practice in the UK, and I think most patients tend to be rescued before they need front of neck access, cricothyroidotomy.
And we would also like to hear from you about one of the other points that we found interesting from the report. It is the second victim effect on the anesthesiologist. Would you like to mention a bit so our viewers may also have an idea?
Andrew, do you want to talk to that?
I mean, Jazz started a little bit in his talk towards the end of it. This was work that was really done primarily by Amira. And, I think what's interesting is that Jazz said that if it's a particularly high risk or emotive situation, possibly more emotive, whether it's a child or a pregnant person or somebody dies, particularly if they die in theatre, the chances of having some effect on the anaesthetist or anesthesiologist were relatively higher. But what's interesting is what happens afterwards. So of those who felt that they were more effective, a lot of those people didn't actually get maybe as much support as you might hope. So whilst most people said that they had informal support from colleagues, people who were more affected said, or they perceived that they weren't getting either formal support within their organisation or referral on to services to help them come through it. And there were some quite extreme examples where some people either weren't able to return to work or had returned to work for a short period of time and then just found it too stressful. They'd changed the type of work that they did, either to avoid children in the operating theatre where possible, for example. So whilst they were small numbers, the narrative from those cases, and there was some free text, was quite striking. I think there's a lot of work to be done there in recognising that. And it's not just, I think that we as anaesthetists are maybe the tip of the iceberg. There's also the operating department practitioners. There might be students in theatre, healthcare assistants who might not actually be captured in the notes of who was physically there. So there's work to be done going forward in how we deal with these situations.
Yeah, I was going to add, so one of the things people said, so most anaesthetists are say they're good at managing cardiac arrest. And of interest, male anaesthetists think they have said it at a higher rate than female anaesthetists. Whether they're actually better or not, I don't know. But males tend to be more confident, according to my questionnaire. But importantly, people aren't confident at speaking to families or leading a debrief afterwards. So if there's a catastrophic event or a critical incident, getting the team together and just saying, is everybody okay? This is what's happened. This is what we're going to do. Make sure you all look after yourselves. If you need any help, talk to X or Y. And then having senior colleagues who support you, and that doesn't universally happen. And I think if you read our report, there's a whole section where people have said, I'm almost thinking giving up anaesthetics or whatever. And the same happens to surgeons and the theatre nurses and so on. That when these events happen, some people get badly impacted in their ability to provide future care. And not all, and depending on your department and your colleagues, you can have a lot of positive support, or you could just have people saying, oh, you shouldn't have done that or whatever. So I think it is an important area. And I'm sure, there is going to be some guidance, and there is more and more wellbeing support for doctors in the UK. And I'm sure then it is an area that needs more work on, firstly, how you debrief an event, and secondly, how you support the rescuers and the team. And the Resuscitation Council UK on its website, and I'll put it in the link in the chat, actually has a resource for rescue wellbeing, and how to debrief and how to look after your team. So that's something that is an important issue, and I'll put a link in the chat.
Actually, we were talking amongst ourselves about that one topic you just mentioned, about that male anaesthetists were more confident than female anaesthetists, and sort of hypothesizing why that might be. And I was thinking about that article in the JAMA last year about female surgeon sex and outcome, where it said that they had lower levels of complications but took longer for the same surgeries. So I was thinking that maybe women are more conservatively estimating their skill set. Do you think that might be, or what is your idea why that difference in genders might be?
I think it was only a small difference, but clearly I think confidence doesn't equate to performance.
Yeah. And I was wondering with both of you how you generally handle do not attempt CPR recommendations during surgery, because at my hospital we oftentimes suspend them for surgery under the idea being that the case is going to be very clear and treatable if something happens during surgery, and so we will attempt CPR. So do you have official guidelines, or is it more like a case by case?
So there is a UK guideline on this that already exists, and if I talk, Andrew can find it and put a link in the chat. from the association. So the usual practice is to suspend the decision, because most people who have a DNA CPR recommendation, it's or if they arrest at home or in a community setting or on a ward area. So when they're in a closely monitored setting, it's often, so if they went severely bradycardic, it would be relatively easy to remedy and treat. So the guidelines in the UK are that they're suspended, but it's important that the surgeon and the anesthesiologist have discussed this with the patient beforehand to explain to them that they'll do things. And when you talk to most people who've got a DNA CPR decision, I think they're okay as long as they're going to recover back to their normal health. What they don't want to end up is on the intensive care unit in multiple organ failure for 2 or 3 weeks and then die. And so if you are going to do resuscitation in theatre, you would be proportionate to the patient's wishes, you know. So if it's something easy to fix, you'd fix it. But if you wouldn't do 2 hours of CPR on them.
Yeah,
that makes sense.
Yeah, I saw Andrew put it in the chat, right? The link, I saw you put it up.
Sorry, I think what's interesting is that the patients who have cardiac arrests just said that about a quarter of them don't get return of spontaneous circulation. And of those who we did have data for at the end, approximately 50% of them don't get to hospital discharge, and about 50% of them do. And the ones that do survive actually have relatively good outcomes in terms of the Glasgow outcome scale. So there's not many in that sort of 4 and 5 bracket which are severely neurologically disabled. So I think that's reassuring, that and it may be a sort of reflection on I think somebody needs to mute. It may be a reflection on intensive care practices and things in the UK, but reassuringly, if you do have a cardiac arrest in the perioperative period, you're unlikely to go home in a severely neurologically impaired state.
And I put a link to the DNA CPR data that Andrew talks about, because we collected the data on all these patients, and there's a paper on that. I just put a link in the chat too.
That's very interesting. We'll be sure to look into it. So I think there are no more questions. Let me briefly check the chat. So I think we should round up and close this session. Thank you very much that you both followed our invitation and gave these 2 very interesting talks. And thank you also for this very fruitful discussion. And I hope we'll see each other again and continue the series of webinars.
It was a pleasure.
Thank you for having us.
Thank you.
Okay.
Thank you.